Dr. Roberto Leon Ferre, Assistant Professor of Oncology at the Mayo Clinic, will discuss a randomized, double-blind, placebo-controlled trial of Oxybutynin for hot flashes.
Thank you, Dr. Osborne, and thank you to the organizers for selecting our work to be highlighted in this press conference. Thank you all for attending. So it is my pleasure to present the results of a randomized, double-blind, placebo-controlled trial evaluating oxybutynin for hot flashes. And this study was done in collaboration with the Accrue Network. This is my disclosure, not relevant for this presentation. So hot flashes are a huge problem across the general population, but even more so in breast cancer survivors. They're very common. They can affect up to 75% of midlife women. And even though most women that suffer hot flashes will experience it for about 2 years, 2 to 3 years as they go through menopause, they can be longer lasting than that, and they can persist in a subset of women for up to 15 or more years. It comes with no surprise that hot flashes can negatively affect quality of life. They affect many spheres of life and can interfere with a person's work, with sleep, relationships, sexuality, leisure activities, and overall quality of life. And breast cancer survivors are unfortunately at higher risk for experiencing either more severe or longer lasting hot flashes, often as a consequence of our therapies. This is a particular problem across patients that have ER-positive or estrogen-dependent cancer, but it's also an issue in patients with estrogen-independent cancer, as chemotherapy can bring on early menopause, but then for those patients that have a hormone-dependent cancer, our treatments often include things that block estrogen and that can block the ovarian function as well. They can also affect breast cancer outcomes, as these symptoms can be severe enough that may lead to patients discontinuing endocrine therapy prematurely, which we know and we've seen from the studies presented at this meeting that there's some data suggesting that some patients will benefit from longer and longer courses of endocrine therapy. So currently there are some therapies that can be used for hot flash management. Arguably, the most effective treatment is hormone replacement, but of course that's not a viable option for our breast cancer survivors or even people that don't have breast cancer but are at high risk of developing breast cancer. There have been multiple studies over the years evaluating non-hormonal agents for patients at high risk of breast cancer or breast cancer survivors, and these include primarily antidepressants and anticonvulsants, and these randomized trials have shown efficacy of several of these agents. However, some of these agents do interfere with the metabolic activation of tamoxifen, for example, and that limits the applicability of some of these drugs. There's also the association, unfortunately, with the taboo of taking an antidepressant or an anticonvulsant when you don't have those diagnoses. Patients may be reluctant to take an antidepressant by fear of being labeled of having a mental disorder. There are several non-pharmacologic therapeutic options, lifestyle and behavioral interventions that have also been suggested to help with hot flashes. However, there's limited data supporting their efficacy. And importantly, even though we have these options, not all patients respond to these measures, and as such, there's a need for additional non-hormonal therapeutic interventions that can be applied for patients that are suffering from this problem. So that brings us to oxybutynin. Oxybutynin is an anticholinergic drug, can be taken orally or transdermally as a patch. It is currently FDA approved for the treatment of overactive bladder, and the doses that are typically used for that indication include 5 to 20 milligrams daily, spread in several doses throughout the day. A common observation that had been seen in patients that take this medication for urinary incontinence was decreased sweating. And that led to several studies assessing this drug for the treatment of hyperhidrosis, and it's been found to be effective in that setting. So that observation led to also the thought that this could be effective in treating night sweats associated with menopause and hot flashes. And there had been some data suggesting that this drug was effective for hot flashes. There was a retrospective study published in 2007, and at the time of us embarking on this study, there were no randomized prospective controlled studies. However, as we had started the study, this publication came along, and they evaluated oxybutynin at a long-acting formulation, 15 milligrams daily, and they found that this drug was effective in hot flash management, but it incurred in some toxicity. So the investigators of that study recommended studying this medication at lower doses. So this is our study design. We enrolled women with hot flashes that had experienced them for at least 30 days, and that had hot flashes that happened at a frequency of at least 20 times per week. Women that were taking tamoxifen or aromatase inhibitors were eligible. However, this was not a requirement for the study entry, so our study allowed patients that did not have a breast cancer history as well. Concurrent antidepressants, gabapentin or pregabalin, which are medications that are used for hot flash management, were allowed as long as the patients had been on a stable dose and were planning on continuing the same dose throughout the duration of the study. Concurrent potent anticholinergics were not allowed due to concerns for interactions and additional side effects by adding oxybutynin to that. And patients were randomized to 3 arms, 2 arms containing the active agent, oxybutynin, at 2 different doses, 2.5 milligrams twice daily or 5 milligrams twice daily. So note that these are much lower doses than what was evaluated in the other study, and that these are on the lower end of the commonly used doses for urinary incontinence. And then we had a 3rd arm for patients taking placebo. The treatment duration was 6 weeks after a baseline week without any interventions other than baseline questionnaires to establish the baseline severity of hot flashes and quality of life. We administered weekly questionnaires, including a hot flash diary, the hot flash related daily interference scale, which is a questionnaire that evaluates how do the hot flashes interfere with several aspects of a patient's life, and then a symptom experience questionnaire aimed towards identifying worsening and several symptoms that could be associated with the drug. The primary endpoint of the study was the intrapatient change in the weekly hot flash score, which is a commonly used metric in hot flash studies that has been extensively validated, and also the hot flash frequency. And then secondary endpoints included the changes in the hot flash-related daily interference scale and change in self-reported symptoms. And I want to point out that this was evaluating each patient against themselves as time went by, not just an average of all patients in the study. These are some statistical considerations, but basically the time average intrapatient changes in hot flash score from baseline during the treatment period were compared between the treatment and placebo arm using a repeated measures model. These are the definitions of mild, moderate, severe, and very severe hot flash to calculate the hot flash score. Patients were stratified by age and by concurrent use of tamoxifen or aromatase inhibitors, and as well by the baseline duration of hot flashes and the average frequency of hot flashes per day. So this is the patient flow. So we enrolled a total of 150 patients and approximately 50 patients per arm. And at the end, we had about between 35 to 40 patients evaluable in each arm due to some dropouts by patients either withdrawing from the study or patients that did not submit some of the questionnaires that were required for interpreting the results. So here are the baseline characteristics. So I want to point out they were well balanced, no differences between the 2 oxybutynin arms and placebo. I want to highlight as well that almost 2/3 of the patients were taking some form of anti-estrogen therapy, either tamoxifen or an aromatase inhibitor for the duration of the study. And we can see that the baseline hot flash score frequency were not statistically significant between the arms. And this is the primary endpoint. So we can see here the mean hot flash score % reduction from baseline. In red, you see the effect of placebo, so approximately a 30% reduction from baseline at 6 weeks. And this is consistent with what we see in other placebo-controlled studies. So placebo does have an effect in decreasing hot flashes. And then in the dark blue, you can see the high dose of oxybutynin led to a nearly 80% reduction in hot flash score from baseline, and of similar, although less demarcated effect on the lower dose of oxybutynin, as well as 6 weeks. And this was statistically significant comparing each arm against placebo. The study was not powered or designed to necessarily compare the 2 doses against each other, but each individual arm against placebo. Here we see the mean hot flash frequency % reduction from baseline, very similar results. And this accounts only for the frequency, not the severity. That's why we wanted to look at the hot flash score as a primary measure. In terms of the quality of life metrics and the hot flash related daily interference scale, we're showing here in this plot the impact in several domains of life. So sleep, overall quality of life, leisure, activities, work, social relationships, mood, sexuality, and concentration. This, the way to interpret this graph is that everybody has been corrected and starts at 0, and this is showing the difference in the changes in those scores compared to placebo. So each oxybutynin arm, the blue for the high dose and the red for the low dose, shows the difference in the score compared to placebo, right? So we can see here that almost all the quality of life metrics were improved by oxybutynin, with the exception of those marked by the asterisk. So none of the oxybutynin doses were able to improve the interference with concentration and sexuality. And in the low dose arm, in addition to those, mood and life enjoyment was not improved either. But sleep, overall quality of life, leisure, work, social activities, and relationships were improved by both doses. So in this type of graph, a negative score reflects improvement. In terms of side effects, changes in the baseline symptoms over placebo, we can see that, again, there were some side effects, some of which are expected by an anticholinergic drug. In this type of graph, a positive score reflects worsening of that baseline symptom over placebo. So we can see that by both oxybutynin arms, things like dry mouth, abdominal pain, and difficulty urinating were worsened to a certain extent from baseline by both arms. And this is somewhat expected. These are known side effects of anticholinergic drugs. The patients that took the higher dose of oxybutynin, so the 5 milligrams twice daily, also experienced some worsening in dry eyes, episodes of confusion, diarrhea, and headaches. All the other symptoms that were assessed by the questionnaires were not statistically significant, so I'm only showing those that were relevant. So how does this compare with other hot flash trials? So one has to be careful when we do cross-trial comparisons, but to try to put this into perspective and bring some clinical applicability to it, we, over the years, under the leadership of Charles Loprinzi, there have been 13 phase 3 Mayo Clinic studies evaluating non-estrogenic medications for hot flashes, and they've all followed the same basic design of having homogeneous inclusion criteria. They've been stratified by similar metrics and then randomized to an agent of interest or placebo. There was one study that was randomized to another active agent. So if we try to put all of those together to appreciate the magnitude of the effect, we can see that across all the placebo arms in those studies, we see a consistent 20 to 25% reduction in hot flash score with placebo alone. Venlafaxine, or Effexor, which is a commonly used antidepressant for the treatment of hot flashes in cancer patients, also leads to a significant improvement and has been found to be superior to placebo, about a 60% reduction in the mean hot flash score. There was another study that compared venlafaxine with another agent, which found very similar results, suggesting that we can, to a certain extent, do these cross-trial comparisons, as the results seem to be similar with the same agents. This is citalopram, which is also used commonly in hot flash management. This is fluoxetine, a little less effective. And pregabalin, kind of similar to venlafaxine as well. This is clonidine, which is not very commonly used these days, but was one of the first agents that was evaluated. And this is oxybutynin, so showing a more significant decrease in hot flash score reduction, although again, this is a cross-trial comparison, so we have to be cautious about that. There's other agents that have been evaluated that have been suggested in the past to be effective, such as soy, flaxseed, black cohosh, magnesium oxide, and vitamin E, and those have not been found to be superior to placebo in randomized controlled trials. So not all of them have been positive. So to conclude, oxybutynin significantly improves hot flash frequency and severity. The use of oxybutynin, more importantly, is associated with a positive impact in several quality of life metrics. Toxicity was acceptable, and while the two oxybutynin doses were not formally compared, 5 milligrams twice daily appeared to be more effective. I want to thank, of course, the patients that volunteered to participate and the Breast Cancer Research Foundation for funding this study.
Thank you. At the Mayo Clinic, you guys, as you pointed out, you guys have done more work in this area than anybody. What is your current strategy for using these variety of drugs? What do you use first now? And how do you work in acupuncture, which is another thing that's been shown to work in several randomized trials now?
Yeah, so I think that primarily We had been using, before this study, we had been using either citalopram or venlafaxine as our first drug interventions. We typically favor venlafaxine, of course, for patients that are taking tamoxifen due to the concern of the potential interaction with some of these CYP2D6 inhibitors. In terms of lifestyle interventions, we don't have a structured acupuncture program. Some of the, we do have acupuncturists, but they have to follow a specific program. It's not any acupuncture, so we don't have a structured program for that, but we often recommend patients to pursue it if they have access to it. We often counsel them with lifestyle interventions, but there's some limits to that, of course. Now, with the results of this particular study, I think we are being more keen on using oxybutynin, and as a matter of fact, many of the patients that enrolled in this study decided to continue it after they had been, it had been revealed whether they were taking it or taking placebo.
Yes, ma'am.
Pam Harrison, Medscape. You mentioned that some women are so bothered by hot flushes that they discontinue, I'm assuming tamoxifen or aromatase inhibitor therapy early.
Yep.
Do you have a sense of what proportion of women, I suspect it's small, but even so, they're supposed to be taking it for at least 7 years, right?
Yeah, or 5 to 10 years, depending on the situation. I think the ranges of treatment adherence and persistence have varied across the studies, while I'm not an expert on that specific area, I think I've seen ranges from 25 and up to 50%. I'm not sure if Dr. Osborne has a more precise estimate.
I think it's up to 30% of patients don't complete the 5 or 7 years, whatever they're supposed to be on. So it's now it's not just all hot flashes, it's other things, joint pain and other things. But yeah, the non-compliance is pretty significant.
Okay, thank you. Just a quick couple of related questions. It seems to me that dry mouth, although bothersome, could be manageable. Are there any interventions you could recommend that women take so to try and alleviate the dry mouth? And a related question is, sometimes transdermal therapy is associated with fewer side effects. It's like in hormonal replacement therapy, they say it's better for women. Is there any sense that if you use the patch in the same dose, that you might have fewer side effects?
Yeah, good questions. So in terms of the dry mouth, as you mentioned, I agree it's something that is common, but most of the patients that experience it, find measures to manage it, and they prefer, obviously we didn't measure this in an objective way, but they typically report that they prefer the dry mouth than the hot flashes, and they always carry a bottle of water, right?
Yeah.
There are some artificial saliva formulations that some patients don't even want to consider, but there are some interventions that can be used to help them with that. And can you repeat your second question? Sorry.
Well, is there any sense that if you use the patch?
Yeah. So you would think it would potentially, by leading to a more sustained release and less peaks in the dosing, that you may experience less of that. I don't have a good sense if that would lead to less dry mouth. I think that the other study that used an extended release formulation would be, it's not the same, but it's somewhat a similar concept. Did see a lot of dry mouth and more, but they used a higher dose. So I think it's a reasonable consideration, but we don't have the objective data to state that.
And just lastly, with this study showing that this drug is really the most effective treatment for hot flashes in this patient population, is this ready for prime time? Should physicians be prescribing it for patients who are bothered by hot flushes? Yeah,
so the drug is available, so people can prescribe it if they feel that this could help. I can tell you that we have been using it, but one has to be cautious about which patients to select for this, because this is an anticholinergic drug. As I mentioned, we were very careful about not including patients that had taken other potent anticholinergic drugs, because these are medications that can lead to confusion episodes, that they can lead to altered mental status, and particularly in the more elderly patients or patients that have suffered from polypharmacy and take many medications that start interacting with each other. So I think that's the main concern. If you're dealing with a patient that doesn't have a lot of other comorbidities, doesn't take a lot of other medications that could interact with it, this is a good option. The other caution that I would like to also mention as a limitation of this is that this is a short-term study, right? So we only evaluated for 6 weeks, and there have been some concerns that anticholinergics, when taken for an extended period of time, can lead to cognition difficulty, memory issues over long term. So we don't have that data in this study. So with those caveats, I think that if we have an informed decision, we could prescribe this to patients, but ideally I would say trying to use it for a shorter rather than longer period of time.
They say that about hormone replacement therapy.
We have to move on. One last very quick question.
Except for allergies, for whom would this be contraindicated? And also, how would you, in terms of side effects profile, compare to the next most popular Effexor, let's say?
Yeah.
If you're talking to a patient about Effexor versus this,
Yeah.
which is best tolerated, and for whom would this be contraindicated beyond an allergy?
So the main contraindications would be, taking another anticholinergic drug. Patients that already have issues with, for example, urinary retention, that would be significantly affected by this. Or patients that are, as I mentioned, have some cognitive issues to begin with. If they have or take medications that could depress their mentation, this is not a good drug. And in terms of how it compares with venlafaxine, I think the side effect profile is different. One of the key differences that makes me more excited about this drug over venlafaxine is that sometimes it is really hard to take patients off venlafaxine. They have to taper and wean off the medication. You cannot stop it abruptly. Oxybutynin you can take and stop as you wish. So that's one of the appealing aspects.
Okay.